Dr. Ho, and this is how we do it.
Intubation. What is it? Sometimes you need help breathing. This may be for a short time, like during surgery, or it may be for a long time if you're not breathing well after being sick or hurt. To help you, the doctors will put in a breathing tube. This is also called an endotracheal tube or ET tube. The procedure is called intubation. The breathing tube goes down your windpipe or trachea to get oxygen into your lungs. The breathing tube can also be put in your windpipe by your doctor making a small hole in your throat.
I have the back. I have so EP2 here. Loose up. I find where it starts ready. Then here we got just running vital signs every 1 minute. Who's gonna be my ears? Oh, one of you will do it. And so Jack, can you check the vital signs?
What to expect during the procedure. You will be given a drug to sedate you, and another drug called a paralytic to help your muscles relax when the tube is put in. While you are asleep, your doctor will put an oxygen mask on your face to help you breathe for a few minutes. Your doctor will then tilt your head gently back to make it easier to put in the breathing tube. Your doctor will use a special tool to move your tongue from the back of your throat. This will make it easier to visualize your vocal cords. The doctor will put one end of the breathing tube into your throat. The tube is gently pushed down until it reaches your windpipe. Your doctor will then remove the tool and secure the tube in place. There is often a small balloon at the end of the tube that is blown up to help it stay in place. The tube will be taped to the corner of your mouth. Your doctor will connect the other end of the tube to the ventilator. This is a machine that will help you breathe. In some cases, the tube is put through your nose instead of your mouth. The tube may also be put through a cut made in your neck. This is called a tracheostomy. This procedure is done if there's something blocking your throat, or you may need to have the tube in more than a few weeks or even permanently. This procedure generally takes less than 5 minutes. What does it do? Your breathing tube is connected to a ventilator. It is a special machine that can help you breathe.
So did everybody see that little square piece that changed from like blue to yellow, And on the video, right at the end of they put the tube in. Everybody see that? They kind of zoomed in at the last second. That's what I'm talking about with the waveform capnography, with the color change. They'll put on the end of that, and that's what's detecting it. If you don't have any color change, it stays yellow the whole time, then you are not in the right spot. It's not detecting that CO2. If you see that color change, of course we're in the right spot. And then she was using a kaleidoscope or laryngoscope. Sometimes they'll have cameras on the end of the blades as well, that visualizes those vocal cords and it eases with that process of intubation. So that's what they were looking at on that left side over there as they were placing it in the tracheal tube. Questions about the process? No? Okay. That was a pretty calm intubation. Sometimes it gets a little more hectic than that. Other than she said "uh-oh" at the beginning, I didn't care for that. But so yeah. Now let's get into more of the ventilator instead of our airway. Let's talk about the parts of the ventilator and what matters to us. Again, we see that CO2 waveform capnography. That's probably important. Our normal values for our CO2, what are those?
35 to 45.
35 to 45. If we're giving this patient all these sedation type meds and we do not adequately ventilate them, what is our initial CO2 going to be? Higher, right? Because we're not blowing off enough CO2. And so we may need to up our rate on our ventilator to decrease that CO2. We have the inline suction. Very similar to what we did in lab with our trach checkoffs, where we were able to get sterile, grab that little tiny suction tubing, pass it through the tracheostomy opening or the stoma, and suction down into our lung space. With our inline suction, however, it stays in place the whole time. It's in this kind of little plastic bag, and it'll actually slide up and down that endotracheal tube so it never disattaches. And so it's pretty good for quick access to that suctioning. If they need suctioning immediately, I can go ahead and give a couple passes and get out whatever is blocking or potentially blocking that airway. So it's gonna be connected to wall suction all the time. The wall suction's gotta be turned on all the time. It's not on an intermittent suction. It's continuous suctioning all the time. And then there's a little valve on the end of your inline suction, similar to the tracheostomy suctioning, where you put your hand over the hole to initiate that suctioning. Same concept, I'm just pressing a button instead of putting my thumb over the hole. So when I press that button on the end of that inline suction, that's when I'm actually suctioning my patient. We gotta think about, again, very similar to the trach checkoffs, our vital signs. Do I need to pre-oxygenate them beforehand? Maybe do 2 or 3 passes if they tolerate it. Allow them to have a break in between. If I need to re-oxygenate or hyperoxygenate again, I need to do that before I have another pass. Every time you're passing or suctioning, you're tickling the end of that trachea and those bronchioles right there and causing that cough and gag response, or they should have a cough and gag response from that. This goes all the way down the endotracheal tube, right off the edge to the very tip. That's where we're suctioning to. It's not going any further down than where that endotracheal tube ends. All right, so we're not getting way down into the lungs, so just think about it that way. There's also something called a CAS tube in your endotracheal tube as well, and it just suctions around the balloon that's creating that seal. So there's gonna be a lot of extra sputum, just junk or gunk around that endotracheal tube that builds up over time, and that CAS tube is actually suctioning it out continuously as well. We've got the ventilator itself. We're gonna talk about several different modes here in just a moment, and what they mean to us. It's gotta be connected to oxygen all the time. So if you're going to CT scan with this ventilator, you're gonna have a bunch of portable O2 tanks with you in the bed so you can change out your oxygen requirements. But usually it's gonna be hooked up to the wall oxygen, and then there's a medical air side too. So there's a green hose and a yellow hose that's gonna both be connected to the wall. And that's how we're delivering our oxygen through our ventilator. Ventilators need to be hooked up to whatever plug is gonna be hooked up to the generator. So if your hospital loses power, the generator kicks on and the ventilator still runs. There is a short battery, but we don't wanna go long-term without being connected to a power supply. East Alabama, it's all the red plugs. I'm assuming it's pretty close to most hospitals. Every hospital I've been to, it's usually a red plug. But just know what facility you work at and what they have from there. Like I said, respiratory therapy is going to manage the ventilator. It is within our scope to look at this though, and make sure we know what oxygen requirements we're on. We have got to assess this ventilator, make sure we know what we're talking about. And so if the respiratory therapist makes changes, then we know those changes. Or we could even suggest changes to the respiratory therapist or the physician and see if they want to change some things up to help our patient out. So just because it's respiratory's responsibility to maintain that ventilator doesn't mean you take a day off or take a step back. Right? Some hospitals will allow you a little broader range or scope of practice with the ventilator and allow you to change some of these settings and different things. So just know what facility you work at and if you're allowed to touch the ventilator itself. We have a humidifier. Why do I need a humidifier? Keep the airway moist, right? So as I'm breathing in through my nose and all those cilia hairs in my nose, what's that doing for me? It's humidifying it, it's filtering it, it's warming it up as it goes down into my nasal passages, into my lungs. So this humidifier is doing all those things. It heats it up and it moisturizes it at the same time. And you'll even see this moisture collect inside the inspiration and expiration tubing on the ventilator as well. And then something like a tube holder. So either that be tape, or a lot of y'all have seen an ICU with the little big brown patches that are kind of attached to your face. That's holding that endotracheal tube in place, all right? It's kind of your basic setup. This is real simple here. But again, you have your endotracheal tube holder itself, and then you're gonna have your ET tube, Usually your inline suction is gonna be hooked up to this end right here, and then you're also gonna have your waveform capnography or your CO2 detector right on the end of this as well. That's gonna be attached up here to the monitor somewhere. And then you have your inspiratory and your expiratory tubing right here, going from the patient to the ventilator. Here's your humidifier at the end. That is heating and moisturizing our air, so there'll be a little bit of water at the bottom of this little bucket right here. It's gonna moisturize that air, and then it's connected to the ventilator itself. Ventilator settings and terms, just general things that you're gonna hear a lot about when you talk about ventilators. All right, so everybody take a deep breath in. Good, let it out. Perfect. That's tidal volume. How much air is going into our lungs at one time? How much air delivery am I giving to that patient? That is what our tidal volume is gonna be, measured in milliliters. It's roughly 6 to 8 milliliters per kg, which is gonna be roughly 350 to 450. There's not an exact science to this. Everybody's gonna be a little bit different. Smaller people with smaller lungs, are we gonna give them a bunch of air? No, because they have smaller lungs. Big guy like me, I'm gonna have a little bit longer lungs, a little bit bigger lungs, so I'm gonna require a little bit more tidal volume, more amount of air to be into my lungs to open them up appropriately as they should. So this is very dependent on the size of the patient. A lot of times they'll calculate the body surface area and then they'll put it into a formula as well to create a tidal volume for us. Tidal volume. Respiratory rate or rate, that's pretty straightforward. How many breaths am I delivering to the patient at one time? How fast are they breathing at one time? That's what we're thinking about with respiratory rate. There's gonna be two different things we're gonna look at as far as respiratory rate wise goes. What the ventilator is actually set at, so how many breaths I'm giving to my patient, and then what is my patient actually breathing? Because they can overbreathe the vent and actually breathe faster than what my minimum setting is on my ventilator. Our FiO2, or our fraction of inspired oxygen, this is how much pure oxygen I'm delivering to my patient at one time. How high can this go? 100%. That's it. You cannot go any higher on the FiO2. There's just not an option. At that point, I'm giving 100% pure oxygen to my patient. That is a very high setting as far as FiO2 goes. Me and you breathing on room air normally is roughly 21%. So that kind of puts it into perspective for you. Usually we like to get our patients to around 30 to 40% before we start thinking about weaning them or taking them off the ventilator and changing them to a different type of oxygen supply. Whether that be a BiPAP or a CPAP at night, or a nasal cannula, or an OptiFlow, or high flow nasal cannula, something of that sort. With that, we don't want them to be on 100% pure oxygen all the time. They can develop oxygen toxicity. So our goal is to meet the minimum requirement that they need. How do I do that? I'm gonna get my arterial blood gas and I'm gonna determine what their PO2 is. So that's a little bit different than the FiO2. So what is the oxygen circulating around in their blood? And that can be whatever. If it's a super high number, then I can turn down that FiO2, wait a few hours, see how these changes are gonna reflect in my patient, and then I can get another blood gas. And then see if those changes, if they tolerate those changes. Can I go down even further on the FiO2? These are not gonna be drastic changes. This is gonna be a slow, steady progress, or it should be a slow, steady process. You're not going from 100% FiO2 to a 30% FiO2. That's a huge jump. So we may go from 100 to 90 to 80 to 70, somewhere in between with that. Then we have what's called a peak airway inspiratory pressure. Peak airway inspiratory pressure, or PIP. Don't get that confused with your positive in expiratory pressure, or your PEEP. So you have your PIP and then you have your PEEP, your PEEP. Your peak airway inspiratory pressure, or your PIP, is the amount or force that my ventilator is working against to deliver that breath of air into those lungs. If they're meeting any kind of resistance one way or the other, so if they have a big mucus plug, this PIP, this peak airway inspiratory pressure, is gonna go up because my ventilator is having to work extra hard, giving extra pressure to actually deliver that breath of air. Does that make sense? Okay. Again, this is gonna fluctuate though. This is gonna be dependent on your patient. So if they had like the mucus plug or something like that, that peak pressure is going to go up because it's meeting the resistance. Once we get rid of that mucus, then our peak pressure should come back down. All right, let's talk about PEEP, your positive end expiratory pressure. So at the end of expiration, our ventilator is going to provide a little bit of pressure support at the end of expiration to keep those alveoli open as long as possible. Because with that, I'm creating that CO2 oxygenation gas exchange. If those alveoli don't remain open, I can't create that gas exchange. So this is having just a little bit of pressure at the end of expiration to keep those lungs open, keep those alveoli open as long as possible. That's our goal. Normal peak is gonna be 5 to 6. When you start getting 15 or higher, that is a lot of pressure that we're having to force into them to keep those lung fields open. So with that, we can have a lot of complications with this. We can create that barotrauma, because remember, it's unnatural for us to ventilate this way. That positive pressure, forcing those airs into the lungs, that is going to be very uncomfortable. So we're gonna create that barotrauma effect. With PEEP, if we continue to up it as well, we can decrease our cardiac output. Does that make sense? Why would it decrease my cardiac output?
Pressure against the heart.
Pressure against the heart, right? As I'm forcing more pressure into our lungs, it's also creating more pressure within that intrathoracic cavity. As it's creating more pressure on that intrathoracic cavity, it's not allowing for that heart to fully expand out, to fully fill up with that good amount of blood in those ventricles. And then when my ventricles beat, it's not allowing for that adequate perfusion to occur because it doesn't have that adequate amount of blood. So the more and more pressure that's created on that heart, the less cardiac output that I'm gonna have overall. So if I don't have enough cardiac output, what am I gonna see on my monitor? What kind of vital sign changes am I gonna see?
A low blood pressure?
Low blood pressure, because my heart is not perfusing like it should. I'm gonna see a low BP. I might also, if I have a SWAN, see a low cardiac output or low cardiac index. All right. And then lastly, a flow rate. A flow rate. How fast am I giving that breath of air? At 350 milliliters of tidal volume. How fast am I giving that? If my patient doesn't feel like it's adequate enough, I can cut it up a little bit and give it to them a little bit faster. Normal is gonna be 40 to 60 liters a minute is what I'm delivering. We can change that up if they don't feel like it's adequate enough, or they're hyperventilating, feel like they're not getting enough air. Because everybody breathes a little bit different, right? Everyone breathes a little bit faster, inspires a little bit faster, exhales a little bit slower, that kind of stuff. So that's what we're creating with our flow rate. There's a lot of other ventilator settings and terms out there. These are the ones I want you to know. These are the ones that are gonna be the most common, the ones that we're truly gonna focus on as a nurse. As you get out into your specialties, you might see a couple other settings out there, because there's a lot that we can do with these ventilators. But these are gonna be the ones that you should know for now. So let's look at a ventilator itself. So this is a Draeger ventilator. Every screen is gonna look a little bit different depending on the brand that you have at the time at your hospital. Back during COVID, we got ventilators from the vet school, where they ventilate the horses and the other things. Ancient looking stuff that I had no clue how to work. That had the little blow valve on it that was opening and closing, the little bellow. And yeah, so I did not want to touch those at all. But everything's a little bit different, so get familiar with your equipment. And I keep saying that, I know, but please get familiar with your equipment. Everything on this side itself for this ventilator is what the patient is currently doing. Not what the ventilator is set at. This is what the patient is doing. Everything on the bottom is what our ventilator is set at, right here. You'll also see the mode of ventilation, which is gonna be in the next few slides, down here at the bottom, but you also see it down here at the top. And then any alarm that goes off is gonna be over here in the top right somewhere, or some flashing light's gonna appear on your screen. So let's break this down while we have it up here. This first one says FiO2. What's their FiO2?
70.
70, is that good or bad?
Bad.
Pretty bad, right? It's kind of high. 70%. It's a pretty good amount of pure oxygen that we're giving to them. Next one, VT. What's that?
Tidal volume?
Tidal volume. It's 360. Is that okay? Probably. You know, we don't have ABGs. We don't have the patient beside us, so we can't really tell otherwise. But 360 is a pretty good normal. TI, I didn't tell you about that one, so we don't have to worry about that. Respiratory rate, 24.
Too high.
Is it too high?
I just took the setting.
Depends on the patient, right? What if they have too much CO2?
And that's probably good.
Then it might be okay because I'm trying to blow off some of that CO2. So all these settings are gonna change depending on what our ABG values look like. PEEP, 8 of PEEP. 5 to 6 is normal, all right? 15 or higher is gonna be pretty serious amount of PEEP. 8's kind of that middle ground.
There was 70%
Probably
needed.
Probably needed, right? Why would I need so much pressure to be blown into their lungs?
The lung was collapsing.
Their lung was collapsing? Maybe, but I might put a chest tube in first and see what happens.
Pneumonia.
COPD, good. That's stiff, non-compliant lungs, right? Pneumonia, yeah, that sounds pretty good because I'm trying to open up those alveoli, right? They're gonna get sticky, have the atelectasis where they clamp down on themselves. What else?
COVID.
COVID-19, yeah. We were showing or seeing a lot of high PEEPs during COVID-19. And then they would go into something called acute respiratory distress syndrome, which we'll talk about in the next few weeks. And we were having to give them so much PEEP because it was taking so much pressure or force to open up those lungs. So you gotta think about stiff, non-compliant lungs when you talk about PEEP. That's our goal. All right, and then the last one says slope. I didn't tell you about that one either, so we're not gonna worry about that one, all right? I did tell you about PIP. That's your pressure on inspiration. How hard is my ventilator having to work to deliver that breath of air? 12. That's pretty good reading. You start getting into the 50s and the 60s range on your PIP, that's when they might have some type of problem or issue that's restricting me from delivering that breath of air. My patient is breathing or pulling in a 354 tidal volume. And he's set at 360. So is he getting the full amount of breath of air that he needs? No. Why not? Any thoughts?
Because he's breathing in.
He might be breathing too fast. How about that? So he's breathing 30 times a minute, and he's only set at 24. So he's actually breathing 6 times over. And so the ventilator doesn't give it a chance to have that adequate tidal volume. And so he might be only breathing 354. Now this is gonna change with every breath. It's not gonna be 360, 360, 360. It's gonna fluctuate or change. Yes?
Those little black numbers, is that like alarm limits?
Yes. These are like 40 right here, there's a 50, 1060, those are your alarm limits. You can change these, but don't change these, okay? The alarm settings are on there for a reason. Don't be the night shift nurse that turns them off because you don't wanna hear, alarms at night. Stephanie?
I might have missed it. I know for the PIP, you said that 50 would be high, and on there it says that I think the alarm would be high. Did you say what the average would be, like what would normal expect?
20 to 30 range, 12 if you have it too low, you might have an air leak. The ventilator is not getting enough resistance or fight back against the ventilator tubing or the patient itself, and it doesn't detect that pressure. So maybe the air is escaping out somewhere. Maybe my cuff is blown, so I don't have an adequate seal, so as it's delivering that breath of air, some air is going further down into the lungs, but most of the air is escaping up and out as well. So that may affect my flow rate. So you want enough flow rate, but you don't want too much flow rate. So you have too much flow rate, it can cause a problem, but too low a flow rate, that could also be an issue as well. So on both ends of the spectrum, we could have something wrong with it. And that's really all we need to know. We have a PEEP of 8 as well. That's really all we need to know about the ventilator and its settings itself. Questions about the different terms of ventilation, of mechanical ventilation? That's all the settings that we have. Now these are the different type of modes that we're gonna have. How can I set up my ventilator? You're only gonna learn about 3 different types of ventilator settings or modes in nursing school. There's a bunch of other options out there, fancier options. So if you get in a more specialty area and they do some cool things with a ventilator, you will see those. But we're gonna break it down nice and simple for us. 3 different main modes. Read your bullet point up top here. The nurse's role is not to set or change settings on the ventilator. The nurse works in collaboration with the physician and the respiratory therapist to manage this ventilator. So it's a teamwork, collaborative effort to maintain this ventilator. Orders must be placed for ventilator changes. In theory. Real world, they'll make some changes and be like, all right, yeah, I got an order for it, and they'll put the order in later. But you need to have some type of guidance. Either the pulmonologist or the intensivist, somebody's got to put in an order telling you to change these settings. Okay. Let's talk about our first mode of ventilation, our assist control ventilation. Assist control ventilation, or AC ventilation. There's 2 different subcategories of assist control ventilation. There's pressure control, where I can control how much pressure or force I'm giving. And there's also volume control, how much amount of volume or tidal volume I'm giving to my patient at one time. A lot of times you're gonna be on volume control, assist control. So you'll see VC, AC on the ventilator. With assist control, this is gonna be our most invasive setting that we're gonna learn about in nursing school. The highest amount, that's the most support that a ventilator can give to a patient. That's how I want you to think about it. So with assist control, I'm giving a set tidal volume. So let's say 350. I'm giving a 350 tidal volume. And I'm also giving a set rate to the patient. So let's say a respiratory rate of 300, ooh, that's a lot. Respiratory rate of 20. So we have a tidal volume of 350, and then we have a respiratory rate of 20. Those are set, those are standard. That is what I'm giving my patient every single time. After those 20 breaths are delivered by the ventilator, if the ventilator senses another breath that's being taken over the 20 breaths, like the patient is initiating, not necessarily the ventilator initiating it, but the patient is initiating that breath, it's also going to give that tidal volume of 350 every time. So no matter what my patient is breathing, he's getting a tidal volume of 350. Okay? So let's look back at our vent here. So he's actually in volume control, assist control up here at the top left, so VC, AC. So let's just pretend, but it actually is. His tidal volume is set at 360. So every time he breathes, he's gonna get a set volume of 360. Our respiratory rate is 24. So we're giving him 24 breaths with a tidal volume of 360. But he is actually breathing 30 times a minute. So he's actually breathing 6 times over what the minimum respiratory rate is set at. Because 24 or 30 minus 24, that's 6. So those extra 6 breaths, he's still gonna get that 360 of tidal volume. Does that make sense? Okay. I know y'all heard this the other day, but it's good repetition, so we're gonna just keep rolling with it. Now, our next setting down. So this is kind of the moderate ground, the medium ground, is your SMIV, synchronized intermittent mandatory ventilation, SIMV. Very similar to your assist control. There's one big difference, and we'll talk about it. So again, I'm giving a set tidal volume. So let's say 350 again. I'm getting a set respiratory rate, so a respiratory rate of 20. My ventilator is giving 20 breaths at a tidal volume of 350. If my patient initiates another breath over that, it does whatever he wants. My ventilator is not going to deliver that 350 tidal volume. So that's your big difference between the assist control and the SIMV. So again, set rate, set tidal volume until my patient starts to overbreathe that vent. Once he starts to overbreathe and initiates more breath than what my ventilator is going to give, he does whatever he wants. So let's look at this one. Remember, our tidal volume is 360, respiratory rate is 24. So for 24 breaths, he's getting 360. Now he's breathing 30. So those 6 extra breaths, he can get a tidal volume of 150, 200, 300. He might get a tidal volume of 360 if that's what he wants to take. So it's allowing my patient to take kind of that small, guppy type breath. Why would I want to do that for my patient? Trying to wean them off, right? So if you're putting them on the ventilator, your lungs are going to get pretty lazy. They don't have to work, right? Because the ventilator is doing all the work of the lungs. So they pretty much just take the day off, take some time off. So I have to kind of work out my lungs, strengthen up my lungs again. And so if I'm allowing my patient to do some of the work, it's like he's working out, getting a little bit more strength within those lungs to see if he's able to tolerate this setting before I go down to my next setting. And then if he's not able to tolerate it, I can go back up to assist control, and then I can give him full support. But this is just intermittent support, giving him a little bit of help and allowing him to do some of the work as well. Questions about SIMV? The last one we're going to talk about is pressure support. You might also call it a breathing trial. You might also hear it called CPAP mode. There's a couple of different terms for the same thing, but pressure support. This is your least invasive of all the types. So before I take out that endotracheal tube, my last mode that I want to be in is this pressure support or this breathing trial. If you think about a patient with sleep apnea that puts on one of those masks every night to help them sleep, all it's really doing for them is giving them a little bit of positive pressure, open up that airway so they can breathe on their own. Same concept here. I'm just delivering that extra support, that extra pressure through that endotracheal tube. My patient is doing all the work at this point. If he's able to tolerate this well, he's able to initiate a breath every single time. There's not long periods of apnea where he just takes a breath, he waits a minute, takes another breath. That's not really tolerating it very well. Then I can go up potentially to that SIMV again. But if he's able to initiate all his breaths on his own, and then I get another arterial blood gas and it looks pretty good, then I can think about extubation or pulling out that endotracheal tube. We may not necessarily go straight from a ventilator and endotracheal tube to room air. There's lots of options out there that we've talked about previously. So again, just that main thing is delivering that PEEP, that extra pressure support to keep the lungs open.
So no matter if they don't initiate the breath, the ventilator will not give the breath,
The ventilator will not give them a breath.
but it will, I'm sure it will alarm.
It will alarm and saying, hey, apnea, apnea. And then it'll keep going off. It's a pretty loud alarm, so you'll be aware. But you're also like thinking, oh yeah, my patient's on CPAP. This is not time to go to lunch. This is like, all right, let me watch this patient pretty closely. If their O2 sats start to drop, that alarm starts to go off. If they're real sleepy or tired, do I really want them on this setting? They have to be able to participate in order to be successful on this setting. So I'm maybe not giving all those sedatives or giving those pain meds because I want them as fully awake and alert as possible so they can participate in their breathing trial or their pressure support CPAP trial. Really the only thing it's doing is sensing that inhale and that trigger, and then it gives you that support. Y'all need a break or we keep going? Good?
Go.
Keep going. Alright. This is a big slide. It's an important slide, but it's a big slide. I don't normally like to read straight off the PowerPoint, but we're going to for this one. What things do I need to worry about if my patient is on mechanical ventilation? They have some type of artificial airway, they're hooked up to the ventilator. What kind of things do I need to consider? First bullet, assess the patient's respiratory status and gas exchange at least every 2 to 4 hours. So every 2 hours, I've got to go in the room. I gotta make sure that endotracheal tube is still in the right spot. So remember those little tick marks, those measurements. If he was at 22 at the teeth when you first walked in, and then 2 hours later, now he's at 10 at the teeth, it's moved. I need to know those things, so I have to check on these frequently. Maybe they developed a mucus plug and I need to suction it out. Or maybe they didn't tolerate that last ventilator change. So there's a lot of good things that I have to assess more frequently than just every 4 hours, periodically just checking or sneaking my head in the door and just looking, oh yeah, he's good. Please assess your patient, it's very important. So anything again from vital signs, if there's any type of hemodynamic changes with your blood pressure or your heart rate, what is their O2 sat, and placement. The next couple bullet points we kind of threw out as well is going to be what's called a VAP bundle, ventilator associated pneumonia bundle. So there's several things that can be included within this. But they're at a very high risk for infection because we have that artificial airway in there that has a direct pathway to the lungs. So they're at a high risk for pneumonia. With our VAP bundle, oral care, very important. We're gonna brush their teeth frequently. We're gonna suction out their mouth. Make sure they don't have any excess secretions. We're also gonna suction out their endotracheal tube as well with that inline suction. So that's all part of that oral care. We're gonna keep that bed in semi-Fowler's position, or 30 degrees, a little bit higher. If they're laying flat down, that's allowing for those secretions to build up, to backflow. And I can also increase my aspiration risk, where I can get aspiration pneumonia with it. So I want them in a little bit higher fashion, sitting up a little bit higher, that semi-Fowler's type position. I'm gonna turn my patient frequently. That allows for the chance for those secretions and stuff to kind of move around and break up so I can get them out with that inline suction. We're gonna do something called sedation vacation, where I cut off that sedation, wake them fully up, see how they tolerate it. Our goal with sedation is to the least amount as possible. We're not snowing every single patient that we have. We're just making them fully out, sedated, no cares in the world. That's a dream ICU patient, but we're not doing that for everybody, okay? Mobility, consider mobility. Can you walk around on the ventilator?
No. I mean, I guess technically.
You can. I've done it several times. I do not like it. It's very scary. But mobility is important. You can do range of motion exercise with them in the bed. Get them to raise their arms and legs. Maybe they can bicycle in the bed. You can also get them to sit up on the side of the bed or dangle on the side of the bed. Get that core workout in. Even them just using a little bit of strength is gonna be helpful in the long run. And then, like I said, you can walk them as well. Maybe even stand, pivot, and get in the chair. That's just that change in position. That's sitting them up nice and high instead of just laying in that bed all day. We're at a very high risk of losing muscle mass with this because of them just laying around all day. Other things, GI prophylaxis. All that acid buildup. We don't want them to develop an ulcer. So they're gonna be usually on something like a Protonix. Y'all pretty much give Protonix to literally everybody in the hospital. So we're preventing that risk for some type of peptic ulcer. And then maintaining that cuff pressure. That's part of that ventilator associated pneumonia bundle as well. Making sure that cuff stays, has an adequate seal on it, not allowing those secretions to go down or up, and allowing us to adequately ventilate our patient as well. And then suctioning as necessary, making sure we're frequently monitoring our patient, making sure they need to suction. And we can suction them more often if we need to, not every 2 hours. I mean, if they need it more frequently, let's go in there, let's suction our patient more frequently. All right, so to recap, VAP bundle, oral care is gonna be big. Keep that bed in semi-Fowler's position. Sit your patient up, that's a big one. Suction when necessary, more frequent than every 2 hours. If you need it, or if your patient needs it, do it. And then maintaining that cuff pressure, important as well. So second bullet point says that 30 degrees or higher, and then review ventilator settings at least every 4 to 8 hours, including alarm settings with the respiratory therapist. This is not something that we check at the beginning of the shift. We go the whole shift, and at the very end, we look at it again. A lot of things can happen. Sometimes our respiratory therapist will go in and just change those settings and not tell you. Or the physician or the resident will go in there and just change stuff because they think they know something, and then you're out of luck because you didn't look or assess your ventilator. And maybe they did a wrong change and something catastrophic happens and you don't know why. This could potentially be why. So I need to know those things. So the next few bullet points again is that VAP bundle. Move the oral ET tube to the opposite side of the mouth every 24 hours. We're trying to prevent that breakdown from occurring. So that endotracheal tube, it can sit in the middle, it can sit on the left corner of your mouth or the right corner of your mouth. On the tube holder, there's little sections or areas that allows it to slide and move freely so that endotracheal tube is not sitting in the exact same place all the time. And then include your patient and your family with care. Remember that sedation vacation. Make sure we're using just the right amount. And at the end of the day, are they able to come off of it? Let's assess frequently if we can wean this ventilator down some. Or if we can't, do we need to get some other source of the airway? So endotracheal tube is not meant to be permanent. 12 to 14 days, and then we need to start to consider a tracheostomy. We don't want a pressure sore to develop within that trachea and create a fistula in there. So 12 to 14 days, I need to start thinking about maybe what are my other options. If I'm nowhere close to being weaned off the ventilator, I'm still on 70% FiO2 and a good amount of PEEP. That's when I'm gonna start considering other options. Every facility is a touch different as far as how long the endotracheal tube stays in. And it also depends on the circumstances as well. During COVID-19, we were using the endotracheals for a very long period of time. Probably not the best practice, but that's what we have. That's what the supplies were. I would know the slide pretty well. You need to know what your role is for your intubated patients. Let's talk about the alarms and what to do in these situations. So remember that PIP pressure, how much resistance that my ventilator is working against to deliver that breath of air. And so that's what we're talking about. Too much resistance, it's meeting too much high pressure, I'm gonna get a high pressure alarm. If it's not meeting enough resistance, I'm gonna get that low pressure alarm. So both ends of the spectrum. Different complications. Increased amount of secretions for your high pressure alarm. How do I fix increased amount of secretions?
Suction,
Frequent suctioning, right?
mucolytics.
Mucolytics, good. Why are they having all those secretions? Is there some type of infection? Do I need to test it? Maybe do a sputum culture? Maybe get some antibiotics on board to fight that infection? I can also have like some atropine drops. That's gonna decrease my secretion. Or maybe a scopolamine patch. That can help with decrease my secretions. There's several options out there for that. The patient is coughing, gagging, or biting. How do I fix that?
Either sedate them or wake them up.
You can sedate them, right? Is sedation our only option?
A little bite guard.
We can have a little bite guard. Why are they coughing and gagging and biting? Are they anxious? Can I fix that issue? Are they in pain? If I fix that pain or fix that anxiety for whatever reason that they might have it, or maybe they're trying to communicate, maybe if I just turn down the lights, they'll be fine. And then they won't cough or gag. So sedation is not necessarily my only option. It's a great option, but it's not my only option. So Sam mentioned a bite block. So it goes right along the endotracheal tube, and this is more of a hard plastic piece. And so instead of biting on the endotracheal tube itself, essentially clamping it off where the ventilator is not able to deliver that breath like it should, they're clamping down on this bite block. And so they're not clamping down on the endotracheal tube, climbing it off. That's a bite block right there. Anxiety kind of goes in with the coughing, gagging, and the biting. Figure out a way to relieve that anxiety. Maybe it's their position changing too. Maybe if I fluff the pillows, they won't be so anxious. Maybe they need some therapeutic communication, someone to sit there and hold their hand for a second. Be a good nurse, all right? Act like you actually like your patients. Pneumothorax. So, my ventilator was set to a set tidal volume and a set pressure to deliver that amount of air to 2 lungs. Now it's down to 1 lung. I don't need that much volume or pressure or force to only oxygenate that 1 lung. It's going to feel that resistance on there and create that high pressure alarm. So displacement of the ET tube can be another one if it goes down too far or up too far, causing a kink in the system, and it's fighting against that kink in the system or fighting against that right main stem. It can cause that high pressure alarm. And then again, the compliance of the lungs. So that stiff non-compliant lungs, those ARDS patients, the COPD patients. Maybe my ventilator is having to work a little too hard to oxygenate them appropriately, to ventilate them appropriately. So maybe I need to up my PEEP a little bit to counteract this. That's all your high pressure alarms. On the opposite end, opposite side, is your low pressure alarms. My ventilator is not meeting enough resistance as it's giving that breath of air. Like I said, leak in the ventilator circuit. Maybe the hose popped off, or there's a hole in my system. All the connections are not tight. The patient starts breathing during that SIMV or CPAP mode. So remember, the patient is able to initiate some of those breaths on their own during that SIMV mode. If that ventilator doesn't feel that trigger to initiate that breath, then it's not meeting any force or resistance to deliver that breath. And so that's how we're gonna get those alarms. So if we continue to get those low pressure alarms, in that SIV or CPAP option, maybe my patient is not ready to be in that mode. Maybe I need to go back up to that assist control mode. Or if it's in CPAP, maybe I need to go back to an SIV mode. So maybe I need to upgrade my mode a little bit. And then a cuff leak, so that little balloon at the end of my endotracheal tube. Maybe it has shrunk down some or it's popped, and now I have a cuff leak. And so as I'm delivering that breath of air, most of my air is going up and out instead of down into my lungs. And so it's not meeting any resistance as it delivers that breath of air. So two different sides. Please know how to fix these types of common complications. This is also table 26.4 on page 616. Table 26.4, page 616. And I'll also put it in Canvas as well. Questions about high versus low? Moving on. Complications of the ventilator. So if I'm on the ventilator a long time, several other systems could be affected at some point or another. There's also a table on page 617, so it's table 26.5, page 617, that kind of goes over the different tiers or categories for the different complications of your ventilator types of events. Let's talk about cardiac wise. Remember, we already talked about that reduced cardiac output. When am I worried about reduced cardiac output? Remember what setting on the ventilator? The PEEP, right? The PEEP. I'm delivering more force, increasing that intrathoracic pressure, which is therefore squeezing my heart, not allowing that heart to open up properly, adequately fill as it pumps. It's not adequately perfusing. So it's decreasing my cardiac output overall. So I get hypotension and fluid retention off of that because my heart is not circulating that blood or fluid as it should. With this, I gotta worry about Valsalva maneuver, them bearing down. If I'm reducing my cardiac output, decreasing my blood pressure, and then they have a Valsalva maneuver where they're bearing down, that's really gonna slow my heart rate down and really decrease my blood pressure. So then I could have a huge event, maybe where they go into asystole or have a big sinus pause, and then I gotta have a whole lot of other issues with it. GI-wise, you really don't think about GI type symptoms when you're on the ventilator, but it can happen. Are they able to eat and drink and talk and do whatever they want to on the ventilator? No. Even if they're fully awake, they're gonna ask you for water. They're gonna ask you for cigarettes. They're gonna ask for all kind of stuff when they're on the ventilator. I have a tube going down into your trachea, down into those bronchioles as they split off. 9 times out of 10, if they're going to drink something, it's gonna go there. It's gonna follow that path of least resistance. Or if they eat something. When they ask for cigarettes, I'm really not sure how they want that. I guess why I didn't put at the end of the endotracheal tube, I'm not sure. But they'll ask you for these types of things. So we gotta worry about nutrition because they're going for an extended amount of time without nutrition. And so that's where that NG tube comes into play, where that potential PEG tube that we may insert at some point comes into play. All those kangaroo pumps that you see that y'all have been looking at, those NG tubes where you've been infusing those medications, remember they all have those tube feedings attached to it as well. And so that's how we're gonna give that nutrition to our patient. And then I can give a bunch of vitamins to them as well. Those protein supplements, all helping with their nutrition status. This is really gonna be monitored by dietary, and they're gonna give you the orders, the set rate, how fast, how often they need to get that set rate. So they'll say tube feeding at 20 milliliters an hour, and then water flush at 10 cc's an hour. And that's what your goal is gonna be, so you're gonna work up to that point. You may not be there initially, but that's where you're trying to work to. So stress ulcers as well, infection risk is a big one as well. With your stress ulcers, something like a Protonix or a Pepcid, something like that. Anybody tasted Toofies before? It's a random question. It's very
Yes.
gross, so, yeah, very salty, so. My brother kept complaining about the taste, cause he would always, have indigestion and said it tastes awful, so. I gotta try it out and see what he's talking about. He was right, yeah, it's gross.